Welcome. Today's FERNE educational opportunity discusses the Dizzy Emergency Department patient and the GRACE 3 guidelines which come to the rescue of the emergency clinician. My name is Edward Sloan. I'm an emergency physician from Chicago. I'm Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. I'm Medical Director for the Physician Assistant Studies Program at Dominican University, and I'm Medical Director for New Rose Healthcare Management, which helps the staff an emergency department in a safety net hospital on the south side of Chicago. Thank you to the EIM group, the group that initially supported my presentation of this information in December of 2022. I have no financial conflicts. I'm the FERNE President and Board Chair. FERNE has educated emergency clinicians for 2 decades in how to optimize the care of patients with neurological emergencies and injuries. What about GRACE 3 and the standard of care in 2024 for emergency medicine specialists and clinicians? Are the GRACE 3 consensus recommendations the standard of care for the frontline emergency medicine clinicians? What about the GRACE 3 guidelines and the standard of care in 2024? Does the emergency clinician have to know how to do an efficient and effective history and physical? Yes. Does the clinician need to be able to do a good neurological exam, which might detect a central cause? Yes. Does the emergency clinician need to know the 3 vertigo types? Yes. Does the emergency clinician need to know what are the likely diagnoses based on which of the 3 vertigo types is present? Yes. And does the emergency clinician need to know how to use rational neuroimaging in these patients with 1 of 3 vertigo types? Yes. Does the emergency clinician today in 2024 need to know how to do the HINTS+ exam? No, not necessarily. Does the clinician have to be able to do the Dix-Hallpike test to detect PCB/PPV? No. Does the emergency clinician need to be able to do the Edlow maneuver when PCB/PPV is diagnosed? No. So we know from this that the emergency clinician must be able to utilize their diagnostic skills and clinical resources in an effective and efficient way in order to figure out what the clinical problem is. However, the use of the HINTS+, Dix-Hallpike, and Edlow are not the standard of care because most emergency clinicians have not been trained in how to do these things in the clinical setting in an effective and repeatable way. What about dizziness and vertigo and EMR, the electronic medical record documentation? How can the ED acute vestibular neuritis patient evaluation be documented using a pre-formatted chart? If there's a dot phrase regarding the HINTS+ exam in a clinician who knows how to do the HINTS+ test, the diagnosis would be acute vestibular syndrome, AVS, and it would then follow with likely vestibular neuritis and the HINTS+ exam. Listed here are all of the things that must be noted in the dot phrase in order to allow for a patient to be discharged safely with acute vestibular neuritis. Note in green that the HIT must demonstrate a correcting saccade on one side, either left or right, demonstrating vestibular system dysfunction, a peripheral etiology. Besides the demonstration on head impulse test that one of the peripheral vestibular systems is abnormal or ill, it is also necessary to demonstrate that there is no hearing loss on HINTS+ exam and that the sensory exam demonstrates no pain or temperature sensory loss because these are posterior circulation sensory functions. Continuing to look at the HINTS+ dot phrase in a patient with acute vestibular syndrome and likely vestibular neuritis and a HINTS+ exam that supports this diagnosis, it is necessary to say that the patient understands what is important to be noted after discharge that would make the patient return to the emergency department if their symptoms change or worsen in any way. Also important is to provide appropriate follow-up, including return to the emergency department if no other follow-up is available. How can the ED dizziness and vertigo patient evaluation be documented using a pre-formatted chart if the HINTS Plus exam is equivocal? Now remember, in a patient with acute vestibular syndrome, if the HINTS Plus exam is equivocal and there's diagnostic uncertainty, it's then necessary to admit the patient for further evaluation, including likely MR testing. How can the ED dizziness and vertigo patient evaluation be documented using a pre-formatted chart if BPPV is diagnosed? In this patient, the diagnosis would be BPPV, and listed here are all of the elements which are necessary in order to substantiate this diagnosis of BPPV. Most importantly, that it's triggered episodic vertigo, that is noted, that there's no acute vestibular syndrome, that there's no systemic cause, no syncope, a normal cardiovascular exam, a normal neurological exam, and importantly, that the Dix-Hallpike test demonstrates upbeating torsional nystagmus, and that the Epley maneuver has been tested or attempted in order to begin to improve the triggered episodic vertigo symptoms that are being experienced. How can the ED dizziness and vertigo patient evaluation be documented using a pre-formatted chart if the final diagnosis is non-specified dizziness? Remember, the non-specified dizziness is a diagnosis of exclusion. Other etiologies need to be excluded before dizziness can be the discharge diagnosis. What does that mean? No evidence of syncope or near syncope. No findings consistent with the 3 types of vertigo. No motion symptoms are noted. No physical exam findings that would demonstrate or suggest a systemic cause. Patient with vital signs that demonstrate no orthostatic hypotension. A normal cardiovascular and neurological exam. The HINTS Plus exam is normal or not indicated. The EKG and lab tests are normal, all suggesting that the patient can be followed up when able to walk out of the emergency department. For more information, email me at fern.org@gmail.com. You can go to our fern.org website or find us at FERNE.org on our social media. We have this content posted on our YouTube channel, and it's available in the small 1-minute lectures on TikTok and Instagram. You can also find us on X, Facebook, and LinkedIn. Thank you for your participation in this educational opportunity today.